So I think we are going to start. So we are really thrilled today to have Dr. Pasupathy to talk about engineering care delivery. But before I introduce our speaker, let me go over some housekeeping issues. Welcome everyone to the Innovative Discovery series. For CME credit, you must sign and must include your email and credentials. Next week, Anastasia Hudgins will visit from Penn to discuss ethnographic research methods and EDUs. And on March 24th, this is on March 24th. And then on March 31st, Neil Goldstein will talk about social and spatial correlates of infection in the NICU. Our next tech talk will be April 6th with Michaela Toffer, who will speak on leveraging cloud, mobile, and big data technologies to support healthy dietary choices. And as always, the full schedule is posted on our website, DE-CTR.org. So everyone, please go on the website. So we are, as I said, we are really thrilled to have Dr. Pasupathy today. Dr. Pasupathy is an expert in system science and health informatics and is focused on both advancing the science and translating knowledge to improve care delivery. He's Associate Professor of Healthcare System Engineering and works at the Mayo Clinic in Rochester in Minnesota. He has a PhD in Management Systems from Virginia Polytechnic Institute and State University. He is also the founding scientific director of the Mayo Clinic Clinical Engineering Learning Laboratories and has over 15 years of experience leading and pioneering efforts in improving complex care delivery systems. So we are really excited to have you here. He has had multiple honors over the years. For example, he received the Informs Innovative Applications in Analytics Award in 2015. He's also a standing study member for AHRQ, as well as for PCORI and for NSF panels. He has had numerous publications and has also published a book on health informatics. So welcome, and we are really excited to hear your talk.
Thank you, Claudine. So let's see, it's between me and the lunch, right? My goals are straightforward, right? I have to be warmer than the main entree and more refreshing than the beverage. So I'm Cal Pasupathy. I'm an associate professor in the Mayo College of Medicine. And so what I want to talk to you today about is, when I met Ryan Arnold and Muge when they visited Mayo Clinic, they were really interested and curious to know more about some of our initiatives, like the Clinical Engineering Learning Lab and some of the other work that we are doing in that space. So today I want to give sort of an overview of some of the initiatives, some of the work that we have, and one of my role, my responsibilities, and I wear sort of two hats, one on the academic side, just as a faculty member, research and mentoring students, teaching courses, postdocs, etc., and then the translational side, which is where we take discovery, we take knowledge, research that we do, and then make sure that it impacts practice. So I see a lot of familiar faces from the Value Institute that I met with this morning. Just quick raise of hands, people from practice, practicing clinicians, nurses, others that actually touch patients, provide care. Anybody in the room? Okay, thank you. Others, administrators, project managers, engineers, IT, other backgrounds? Okay, that's good. So, before I jump into sort of the topic or the discussion, this is what, one of the roles as part of the Kern Center, which is where I spend 70-80% of my time. I lead a team called Information and Decision Engineering. So this is a team that actually brings together a lot of expertise in optimization, operations research, informatics, statistics. And as a collaborative team, we take on those challenges where we have to discover, bring sort of the methodologies around machine learning, data mining, modeling, and we'll talk about some of the examples. But then how do we also get it translated, implemented? So, really great team that we have. Some of our postdocs that have been spending time on leading efforts in various embedded areas ranging from surgery to emergency medicine to in the inpatient setting, ICU, etc. So today I want to focus on, as a team, again, we have areas and projects that we work in, looking at a disease progression, for example, ALS, or looking at surgical site infection, using data mining methods to be able to discover some of those patients' safety issues or challenges around infection. We have other areas where we focus on using advanced modeling, analytics, data mining for relating to care delivery for cancer. But today I'm not going to go over all of those. I mean, we sort of take the various research and the translational work that we do, and we have sort of 3 different areas or categories that we have them in. One is sort of which is more operations or systems focused, which is easy translation to be able to impact entire departments. The second category is around medical clinical decision making, which gets into studying disease progression, being able to understand pathways, being able to translate that and say, how does this impact patient care? What is going to happen to the patient in the next 6 months? What can the clinician do, bringing together what evidence exists in the literature and what we are finding from data to be able to translate them into decision tools and provide that information to the clinician so that it is actually, enriching experience for the patient and the provider during their encounter. So that's the second level of research area. And the third one is more policy-related questions. But again, I'm not going to elaborate on the second and the third today. I'm going to primarily focus on the first area around in those, specifically in the surgery space, and talk about the Clinical Engineering Learning Lab, which is one of our initiatives, both in the emergency department and radiology. But I'll primarily focus on the emergency department for today's talk. Radiology is something that we kicked off, and I still remember the date. It was October 24th, birth of our first baby, so I can never forget that date. Or at least my wife will make sure I never forget that date. Some of the challenges from an operation system standpoint, again, this is where this is not a challenge just from a patient standpoint or from a provider standpoint, aka a surgeon, nurses, or the surgical team, but this is something that the institution faces as well, but the challenges are very different. As a patient, oftentimes the challenges are when I want to see a physician, a surgeon, when I want to make sure that I'm able to get a certain a procedure done, access is a critical issue. And again, I'm talking about micro level access. I'm not talking about access at large where we are looking at the insurance aspects. Again, I'm really focusing on, as a patient, they call in and they should be able to get an appointment at a reasonable point in time. Because, several institutions here in the United States, and this is a global phenomenon where national health systems, in Canada, you go to Europe, oftentimes the challenge is getting into a health system to get a certain procedure done. Oftentimes, it takes several weeks to months. And we see that at Mayo Clinic as well, where patients come into the clinic to see a surgeon, and then the surgeon says, looks like Mr. Smith, we need to operate on you. But only to find out that the surgeon is booked out for 3-4 months into the future. But we know that information. We know that the surgeon is booked out so many months into the future. Why don't we use that information up front? So that's a challenge from a patient standpoint. Also, from a patient standpoint, on the day of surgery, oftentimes they come in, there are delays in the morning because, people are running around trying to get the day started with the first procedure, but then there are delays with the first one. There is a trickle-down effect. So that frustrates everyone in the operating suite. It frustrates the staff on the floor. It frustrates the clinician. Patients are dissatisfied. Administrators are helpless, not knowing what to do. It affects the utilization. Institutions have invested so much money into the operating suite, and every hour that's not spent is actually money wasted. So then we end up starting late, but you still need to get procedures done, so you end up going overtime. Now we are paying overtime for staff. So it's a double whammy. You end up, not using the time that you already have, but then you end up going overtime and then having to pay overhead on that. So this frustrates administrators. So these are challenges that are all, different levels, different stakeholders, but then if you come back to it, really gets back to how can we coordinate this and be able to address some of these challenges. So as part of, when our team looked at this challenge, we actually broke it down into multiple levels. So there are different kinds of problems that we are addressing here. So I'm referring to those as tactical and operational problems. So tactical is where you're trying to plan for something for the next 3 months, next 6 months, and so on. So these are things, for instance, like how do I allocate blocks to surgeons? How do I make sure that surgeons get so many operating hours? I also want to be able to look at things like balancing. So in the case of Mayo Clinic, so we have surgeons. So surgeons, they have some time that they are in the clinic and other times they are in the OR. Those are not totally independent things. If you think about it, the more time a surgeon spends in the clinic, the more patients are going to come into the system. But the more time you spend in the clinic, you're taking away time from surgery. But then if they are in the system, you need, again, a corresponding amount of time in the operating room so that the patients can get operated and move on with their lives. So this is actually a very connected problem. But then if on the flip side, if you take away from clinic time and put it for surgery, then you don't have enough patients and your OR ends up being starved because you don't have patients that come in. And so it's actually, that actually plays out into access for patients. So those are kind of more, the tactical. And then if you get into the operational, I was just describing the access clinic dynamic. Once they get into the system, then we want to make sure that we are scheduling them so that the delays are all avoided. We are effectively utilizing that 8 to 5 time, which is called prime time utilization from the institutional standpoint. But then the more effective we are in predicting those procedures, the duration, and then scheduling them, then we don't have to deal with the headache of late surgeries and overtime and et cetera. And here's where this leads into fatigue, burnout issues on the surgeon and the surgical team, workload, it gets out of control. And there is literature, strong evidence that points to the fact that surgeries that are done outside the normal operating time have a higher likelihood for errors. So I don't want to be operated at 9:30 at night. So I'm going to focus on, so I showed you the overview of those 3 major areas. So I'm going to focus on primarily the 2 in the operational space for now. The one in the capacity space is actually something that we have developed some tools, and we are in the process of initiating a pilot, which is going to start end of this month, beginning of April, I should say. But for today's talk, I'm going to focus on the operating room utilization and the access to clinic surgery aspects of it in the operational level. And specific use cases that I'm going to use are where we did a pilot and demonstrated impact on the operating room utilization for spine surgery, and the access to surgery, access to clinic surgery component where we worked with colon and rectal surgery. I'm going the wrong direction. Okay, so operating room utilization. So when you talk about operating room utilization, there is a lot of research, there's a lot of evidence out there studying what is operating room utilization, how much are we using our ORs, how are we scheduling. But what has been lacking over the years is being able to translate that and say, how do we bring in the expertise that we have in data mining, prediction, machine learning, which people have spent years really talking about it. And again, over the years, what we have done is, from a descriptive space, we have collected data from the past and said, well, this is how our procedures, this is how our ORs have been scheduled, and this is how we should have scheduled it, but the translation component has been lacking to be able to go back and say, how do we do that? So there's, descriptive pretty much has been really taking that historical data and developing new models or testing hypotheses. In the predictive space, again, there is potential with large amounts of data that we are acquiring there are data marts and institutions spend time and effort really warehousing that data. We can really move to that area of saying what might happen. For example, given a patient's condition, given who's the surgeon operating, given all the other factors, comorbidity factors, we are able to predict with reasonable certainty what will the duration of the procedure look like. So moving into that predictive space of really looking into the future. And then there is the prescriptive component, which is where, okay, taking that information, now I'm trying to decide what should be done. I give the example of the weather analogy. Assuming that the weatherman can be right, oftentimes, they are able to. But anyway, looking at the past to say, April 15th for the last 10 years, this is how much rain we've had. That's really descriptive analytics. Taking that information and saying, we expect, 5 inches of rain whenever you're predicting or projecting into the future. That's predictive analytics. Now taking that information and translating to say, you should carry an umbrella or you should carry a coat because the temperature is going to be cold that day too. So that's prescriptive analytics. So this is kind of the area that we are in where we can actually bring that together to be able to move into that realm in health services research. And then, of course, once that discovery is done, again, this discovery has happened in several other industries. Healthcare has spent a lot of time and effort in those top 3 boxes. What health sciences research has not done effectively is being able to bring those together and move to implementation, translation, implementation, and evaluation, which is why care delivery science is so very important, because we live in that space of implementation as well. So it's not discovery versus practice. How do we come together to be able to bridge that gap? So what did we do in that descriptive analytics phase is we actually went back to surgical notes, really to look at different types of procedures. What are factors that might be there that might be affecting actual surgical duration? Think of historical data, trying to pull that data and trying to better understand it. We're really trying to explore from data, from historical notes, what happened and what was related to what else? What are trends or patterns? And those are the questions that we are asking here. We are testing hypotheses. This was very iterative. So we get data, look at something. We had a great presentation by Claudine this morning about bringing together data from different sources. But then again, you go back to look at the data that you have clinical input. Something's not right. You go back to get more data. It is very iterative. So you get clinical notes, you try to understand that, look for text mining, look for patterns. Things don't make sense. Okay, go back. We need maybe an additional variable. We need to go to a different data source and get an additional set of variables. Go through that process. Some of it is structured. Great, we can use that data as is. Oftentimes, a lot of it sits in those unstructured text notes, the messy stuff that traditionally we don't want to touch, we want to stay away from because it's easy to work with numbers and codes as opposed to text. But for better or for worse, text has a story to tell. So that can enrich what the data can give us. So that's where we bring those together. We actually did that descriptive analytics, really looking at things like different parts of the actual operating procedure itself. As soon as the patient is brought in, time to incision, they're being prepped, the tubes inserted and the anesthesiology work, and then the actual operating time, which is skin-to-skin time, and then finally, stitching the patient back together, and then closure to exit when the patient is wheeled out of the room. So those are 3 different aspects to the actual surgical procedure itself. Factors that might affect it, we're talking about spine surgery here. So here is where it's really critical. What might be important in spine surgery is not going to be important in colon rectal surgery. It's very dependent to the actual procedure, very dependent to the patient, dependent on the operating team for certain things. One of the things that we found was procedures where the patient is facing upwards. Supine is going to be different from accessing the spine from the back, because you don't bring the patient facing down. You always bring the patient facing upwards, but then the time involved in just flipping the work that's being done and then flipping them over is going to affect your time itself. Number of levels on the spine being operated, that's going to affect not the first part, but more so the actual operating time. So these are all things where we looked at historical data, asked specific questions. Other factors from a patient standpoint were things like obesity, which affected operating time duration. Then we moved into the predictive space. How do we use all this information and say, what does this mean? What can we say about what might happen in the future? So trying to project, trying to predict what's coming. We took all that information and then we said, okay, let's build some predictive models. One of the things that we wanted to predict was that operating time duration. We looked at ASA levels. So anesthesiology does a rating of sort of the complexity of the patient, if you will, based on their comorbidities and all that. So it's a simple scale which they evaluate, based on the patient on the day of surgery. So here's a great example of what data that you can get retrospectively versus what makes sense, what makes sense in actual practice for implementation. Because I can go after the fact and get the data and do all the analysis and say, oh, ASA level is a strong predictor. Great. But guess what? ASA level is done only on the day of surgery. We are trying to schedule a procedure, 3, 4, 5 weeks before the actual procedure. We're not going to have the ASA level data. So the question is, what do you have on the day of scheduling the procedure? So even though ASA was a predictor, we came up with a proxy as how healthy is the patient, yes or no. And so we sort of created that as a binary variable and linked it to ASA level to say, if the patient is severe in these 1, 2 levels, then, yes versus 3, 4, 5, no. So we sort of arbitrarily created that, but again, with clinical input. And mainly, if this variable is going to go into production, when it's being actively used by the the surgeons in the clinic, they need to need to have some sort of standardization so that different people evaluating the patient, different surgeons have to use a similar sort of standardized approach of evaluating, but to also stay true to how we've actually modeled it. So that's where sort of the education component of translating what we found versus how it's going to be implemented comes in. So we had that a sharing of that. Again, looked at a number of levels, which also was a strong predictor in terms of the duration. Translated all of that into a UI. So think of it as a surgeon is in the clinic with the patient. They bring up this tool. They just enter all this information, populate it, and then say, hit submit. It's going to automatically compute those durations. That's the prediction part. So this is on the left, you have the discovery part of the predictive analytics. On the right, you have the implementation component, if you will.
What about, can you go back?
Sure.
So picking up on the ASA thing, calculation of the ASA is not rocket science. I mean, anybody could do it. So how do you decide whether to put a proxy in or just talk to your neurosurgeons and orthopedic surgeons? That they calculate, they use functional scales which are much more complicated than ASA, like the Westbury index and stuff like that.
Right.
How about just saying, we need you at the time you put a request in for surgery to tell us what the ASA level is? I mean, or have the nurse do it or something. As long as it's consistent and has the validity and reliability of anesthesiologists, and God knows what that is.
Right.
So how do you decide which one you want to do? Do you actually model both?
Great question. So 2 questions that I would ask. Number 1 is, how critical is that metric for whatever my outcome or whatever I'm trying to predict or whatever decision I'm trying to make? How correlated? How important is that metric in that the feature space? The second question is ease of implementation. So if I find that something might be 99.9% important, I better find a way to get it implemented. But something might be 50, 60% important, but then if it's going to take a lot of effort and pain in actually getting it implemented, because I have to pull from 3 different data sources and then bring it together and run it through my algorithm, I don't know if it's worth that pain, because here is an example of scientific rigor to practical relevance. So, I mean, I rather have something that's I'm satisfied with, which can go into implementation so it can actually have an impact on patient lives in 2-3 months, than have to work on a Ferrari, which I'm not going to be able to drive for the next 5 years.
You could always add it later, upgrade it later.
You can always, yes, you can always revisit these if you think it's not adequate enough as part of, what, I mean, I think what healthcare is also needs to get used to is, I mean, I know things are at stake, patient lives are at stake.
What's good enough?
What's good enough, and also this notion of it's okay to pilot, iterate on certain things and fail, so we go back to the drawing board sooner than waiting for several months for the discovery phase to happen. So moving into the prescriptive analytics, we take the duration and then trying to figure out how do we schedule this. So think of these as blocks. So I have 4 rows here. Each row is sort of a block for the surgeon itself that's actually will be operating. So I'm trying to schedule the to-be scheduled procedure. So that's the patient in my clinic. I want to schedule the right time for them. Things I'm factoring in here is if I schedule the patient on the first day, I'm going to run into overtime, which means I'm going to be incurring staff cost. If I don't schedule it, that's an imminent day because that's here tomorrow, which means then if I don't schedule it, I end up having undertime. Undertime is also costing us money, remember. Day 2, there's nothing else scheduled, so it's pretty much empty. If I put it there, great, at least I'm going to use some of my OR time. But here's where I have a decision to make, because if I leave it, if it's way down in the future, that empty day, it's great because I can hold it for one of those longer spine procedures. Typically spine procedures are like much longer in length, they have a lot more variability. But again, there are the ones that actually run for 10, 15 hours in length, those procedures. I might want to save the second row for that particular type of surgery. But again, I would do that only if that day is way into the future. The reason is because I'm already here. It's very unlikely I'm going to get a really complex patient for 2 days from now to be able to schedule there. So those are factors that go into this prescriptive component. Okay, schedule it here versus here, that kind of an algorithm that we develop. And this is the UI taking that information to be able to bring the current state of the calendar for the surgeon and then helping them figure out when should they schedule it. And so here one thing to note is oftentimes there is also challenge across, being able to schedule across surgeons. The reason is because sometimes a surgeon might see a patient in the clinic, but then they have the difficulty to get them scheduled soon enough. In some other practices, the surgeons work, they have their partners that they, 2 or 3 people that can actually work and operate on similar patients. So they can pose the question, would you be okay if this other surgeon is actually available sooner than I am? Would you be okay? So this actually provides a much more interactive, really makes the information, the underlying the challenges visible, so that can be used to be able to make those immediate decisions. So we implemented this, and then we had a 6-month pilot, and the key things that we were after, being able to focus on effectively using the utilization, and then not having to delay, having days with no surgery or end up having overtime. We were able to make a positive impact on all of those key metrics. So that's the tool that we had called the Hour tools. Hour is Greek for time. It's actually one of the IT programmers came up with that name. It was pretty cool, I thought. And so we use that name. I'll switch gears, go to the other work that we did in surgery around patient access. So the previous example was great. I mean, again, there is a little bit of a patient component, but really the primary focus there was more from the institutional standpoint and the clinical team standpoint. Now let's look at patient access. This is a dense graph, but let me walk you through it. So I have a time scale or the timeline on the x-axis. On the left side y-axis, I have pure counts or numbers counting. On the right y-axis, I have number of days. The blue line that you see is actually listing per 2 weeks. So these are all, think of this as patients coming to a clinic and their need to having surgery. So this is the demand for surgery, if you will, or the volume, the number of patients that are requiring surgery. The line above that, I'm colorblind, especially when it comes to some of these colors. The line that's right above the blue line is surgeries per 2 weeks. So that's the rate at which they're able to operate on these patients and get them through the system. Remember, I talked about clinic versus operating time, and there is a difference there because there are emergency cases, emergency add-ons. That's why you have the red line that's slightly above, which is surgery per 2 weeks. So that sort of gives us a sense of what is the demand for surgery, and then what's the rate at which surgeries are being performed given our current capacity of surgeons and operating rooms. Now, the line that I have way down, so for the first two graphs, I want you to look at the left y-axis. But the line that I have way down, which is what days between listing and surgery. So that is our access metric. So in a way, think of it as a patient comes to the clinic and they want to have surgery. How soon can that surgery be scheduled? So that's days between listing and surgery. As you see, up until spring of 2013, that line is way down there, and it's averaging or hovering around 3 days. Because remember, I go by the y-axis on the right side. So up until spring of 2013, it's only 2 to 3 days or around there. But then we had a new patient initiative in spring 2013, so the blue line shot up, which means our demand went up. But nothing happened to our the red line, because we didn't make any change to that. So as soon as the blue line shot up, we had more patients, and then it went back down. But because of that, you see the green line, which is that our access metric, it just went drastically up. But that backlog in the system sustained, even though the original demand went back down. It's almost like you have a tub or a sink, and then you have a faucet, you have the drain. So the rates are both the same. You have water entering and then leaving at the same rate. Now suddenly you increase this. You have not done anything to the drain. You just increase this, turn it up, a lot more water coming in, and then turn it back down to the original level. Even though you turned it back down, the water level in the tub is going to be much higher. So that's essentially what we are seeing. How did we address this? So this was one of the analysts, Todd, actually put this together. This is such a powerful graph for us because this really motivates the challenge that we are facing. How did we go about this? So we said, what are the key factors that are important in improving access of patients to get them into surgery? So one of the key things was really the patient indications when they call in. Are we talking about a colon cancer patient or diverticulitis or Crohn's, or what is it? So the primary indication was going to be critical. Other factors that also played in are things like, where is the patient coming from? Is this a local regional patient? Because Mayo is also a destination medical center, so we have patients from all over the United States, plus from rest of the world, from countries in Europe, South America, Middle East, and so on. So we attract large patient populations. So we need to provide care to the local patients, but at the same time, we need to provide care on procedures for all these other patients. So we took all that into consideration, and we came up with a prioritization matrix, which is what you're seeing on the left side, taking all those diagnoses, and then with those referrals and the type of patient, we prioritize. So like, for example, a colon cancer international national patient is going to be priority 1 because depending upon if they're already on campus, it doesn't make sense to have them to go back and then come back again. So they're priority 1, which means they would get operated in a much shorter time span, as opposed to someone which is at a lower priority level in terms of the diagnosis, who is a local patient, because they can come into the clinic anytime. They don't have as much restriction. So these factors played into the logic of the ranking. So we took that information and then we came up with target times and maximum wait times. So it's sort of tuning. Again, based on those, you're going to have a patient demand for each of those categories. So your demand is going to dictate what this time window looks like. So for example, colon cancer patient, we wanted to get them operated from within 1 to 3 days, as opposed to Crohn's or diverticulitis, which might be more 5 to 15 days range. So we're able to stagger those. So if you think about it, you walk into the ED, first thing that happens is triaging, right? If you're the most severe, sickest patient, then you go up the list. We're pretty much doing the same thing here. So that's translated into a decision support tool. So this actually happens really at the point of scheduling, because we know the surgeon's calendars. We know all this information right at that point. Instead of waiting until the clinic, waiting until the day of surgery and trying to figure out, okay, how do we get them in? Let's be proactive. Let's do it up front. We have all this information when the patient calls in. So the challenge of which surgeon is booked out is already addressed, because when the patient calls in, we send them to the surgeon who does not have as much of a backlog in their workload. They may not have as many patients in the clinic or surgery, so then send the patient to that surgeon as opposed to others. So we also have a classification of which surgeon can do what type of procedures or what types of patients. So that's implemented, and we are actually going into a pilot for this work. The pilot is actually ended end of this month. We have the results, and I was looking at some of the initial results. The listing to surgery, remember our access metric, the one that shot up and stayed up there, that's actually drastically improved. And again, we are breaking it out by those critical patients. Priority 1 patients, it's actually improved a lot more, which was our original goal going into it. The PACs, we call them PACs, they are the patient appointment coordinators, people that actually schedule the clinic appointments. They love the tool because it's almost like you enter just a couple of pieces of information. You enter the clinic number, it already pulls up their name, and then you have to enter a couple of indications, and then the tool pulls up all the surgeons' calendars and says, send them to this particular surgeon already, and also provides optional surgical dates. So what we do with the tool is we sort of pre-list and hold a date. Of course, the patient does not know that we're not really scheduling them, we're just holding a tentative date. And then once they go into the clinic, because this is a high priority patient, we're already holding a date for them if they need surgery. If they don't need surgery and nothing gets scheduled, the date gets dropped out of the system. So the results are actually looking good. Maybe in a month or two, we're going to wrap up the evaluation, and then we'll be both disseminating the results as a manuscript, but we also have the tool already operational, and they want to continue using it. And I was mentioning earlier that Mayo as a whole is migrating to Epic. So we are starting some of those discussions about integrating this with the Epic universe. I'll switch gears and talk about clinical engineering learning labs. Globally, there are challenges with emergency medicine, emergency care, where patient volume, especially in the United States, because of our type of insurance system that we have, oftentimes patients with chronic diseases end up in the ED. The volumes are increasing. Their complexity is also increasing partly because we are all aging, so there is more diseases, more comorbidities, and these patients, we find a lot of them in the emergency department. So this is, ED ends up being that focal point where it all really comes and hits them, and it's one of the most challenging professions from a clinical standpoint for physicians, nurses that work in the ED space as well. Traditionally, of course, we have looked at it from a top-down approach to say, okay, let's build process maps and study this and see what happens, and let's try to address each of those things. Research has looked at it more from individual patient cohort basis. Let's look at this cohort, mental health cohort versus those that come with chest pain, which is all great information. But we have to figure out a way, how can we bring it all together and get that rapid cycle of getting it implemented so we can impact. So that's where we went by, one of the founders of Mayo Clinic, one of the Mayo brother, he mentioned that the best interest of the patient is the only interest to be considered. I'm sure you will all agree with that. But what's our driving theme is the last part of that sentence, where the union of forces is necessary. Healthcare is an environment where no single individual at any point in time can do anything. We are all, the patient is the one that we are trying to provide the best care to. But how do we come together to be able to provide that care? So that's our underlying driving force behind how our team, the cell team, comes together. So it's really a partnership between the Kern Center for the Science of Healthcare Delivery and a clinical department. In this case, because of challenges in emergency medicine, that's our first cell. And really bringing together that expertise background in operations research, information decision engineering, human factors, social science, cognitive science, economics, computer science, bring it all together. And again, this does not have to be 100% FTE working in that environment. These are all people that are working on other projects. So it's sort of a cluster that comes together to be able to address those problems. And maybe once the project is done, they go on to work on other things. Maybe when other projects arise, you come back together. It's sort of a dynamic, adaptive cluster that comes together. But of course, our underlying principle is we want to have that agenda of advancing care delivery science, impacting practice. Any initiative, any project that gets initiated, we keep asking these questions. And we have that agenda in terms of the research or the science of how we do it. As the way it's structured is we have a ED pediatrician, Tom Helmick. So I do introduce him as the real doctor. So when we are in the room, I'm not the real doctor. So he's a medical director for ED Cell, and I'm the scientific director. So again, we make sure that keep questioning that we are advancing science and making sure that what we are doing is not research that's going to sit on a shelf at the end of the day or a publication, but really it's going to change lives in a positive way. Very, very, very vibrant environment. We meet on a weekly basis for 4 hours, although because we were in the ramp-up phase, the initial startup phase, we were meeting every week for 4 hours, Tuesday afternoons. But since then, we've actually gone down to twice a month for 3 hours or so. And that's because we needed a lot of time and effort and investment to get it going, but now we are starting to cruise. Some of the effort that we had to put in were things like being able to fundamentally build that data infrastructure, bringing together data from various sources so that we create that data mart or the research data sandbox, if you will. So questions, not only clinical questions, not only questions that are specific, for an RCT, but also questions around things that can impact care delivery at large in the ED space, actually come to us so that we are able to triage, look at it, provide quick evidence, quick support, or quick ways to improve it, or also ask some, scientific question from a methodology standpoint. The listing of major projects here, again, wide gamut of projects, some that are more in the informatics operations research space, and then we have some that's focusing on interruptions, cognitive load, and Kristen would be very interested in those. So a colleague of mine, Ronaldo Blocker, so he leads the project on interruptions and cognitive load. And then we have others that are more, our team activation is another really important one. So we're really trying to look at when there is an R team activation in the emergency department, one, what does the journey of that particular patient look like? When do they come in? How long do they stay in the resus room? And where do they go? But two, equally important, whenever these happen, staff are being pulled away from the existing pods. So the critical question there is, what's happening to the patients left behind in the pods when you're taking staff away? So we're starting to look at what is happening to those patients. Can we come up with alternate protocols to be able to make sure that their stay and their care is not affected by our team activation? So I'm going to highlight a couple of the projects in this space. One of the projects, these projects that I've led, and the first one where I was a co-lead with another colleague of mine who is an optimization expert, Mustafa sir. Here, the primary notion was, first thing I'm sure that comes to mind when you talk about emergency department, especially in the evening, is waiting. I don't think anybody would argue with that. So the question that came to us was a challenge in terms of patients waiting in the waiting area and some of our high, severity patients not being able to get timely care. So fundamentally, this goes back to a match between capacity and demand in terms of when you have patient demand, you need to have enough capacity so that they can get through the system. If you don't have enough capacity, you're going to have waiting. That's a law of nature. There's no way we can get around it. But how do we go about it? So we've built this environment where we can bring all this evidence. So we looked at historical data, and then the gray bars in the back end is sort of our capacity, which is pretty consistent across the board before the work that we did. The arrivals are the ones that you see, patient arrivals based on timestamps at the bottom. Patient volumes is actually really, the blue line, for instance, if you look at patient volumes. So what was interesting here is you notice that on Monday mornings, that blue line creeps above that gray area, which means there is more patients, more demand than there is capacity. Look at Thursday morning. So why would we staff the same number of people on those 2 days? It doesn't make sense. We don't need to have additional staff added. We don't need to hire new people. It's just moving things around. So, and of course, but this is a really sticky issue because, we're talking about changing shifts, which is really challenging. And two, because up until this point, staffing was done separately for physicians, separately for nurses, separately for residents, APPs. But this was the first time we said, no, this is, and interestingly enough, our focus was initially only for physicians. Nursing leadership came to us and said, well, can we also be included in this initiative? We want to look at ours as well. So that's when we had an aha moment in our team. For a patient to get through ED, you need three things to line up. You need a doc, you need a nurse, and you need a patient room. Even if one of those is not available, the patient is not going to be able to go through. So that was our underlying principle to be able to say, okay, how do we bring it together and model this? So when we looked at historical data, we looked at trends or patterns. We talked to the docs and said, approximately how many patients can you care for at any given point in time? And they said, well, 11 to 12 patients. Well, we went back, looked at the data. And what did we find? We found that when you have up to 7 or so patients, their length of stay was averaging around 3 hours or so. That the initial you have shoots up, but then the variation is really compact or dense. But then when the number of patients that they are caring for at any given point in time is over 7, that actually increases by an hour. Their length of stay of the patients on the average increases by an hour. So there was a critical threshold. And when the clinicians, when the nurses saw this, and they validated this to say, this is true. I mean, we are seeing this. But up until this point, we didn't know a way to say, where is that threshold? How can data prove it to us? But we didn't stop there. So if this were purely research discovery, we would have published this paper and moved on. But we said, no, we're going to take this, come back to move our schedules. And the schedules we moved again with stakeholder input. We did a pilot. We had again, ED is a very seasonal environment. It varies over time. So we wanted to look at same time frames for 3 different years. So we wanted to establish our baseline first. I mentioned volumes are increasing. All patient registrations for those 3 time periods, pre-1, pre-2, and the post. You can see the increase there. Second point was ED level is a metric around the complexity of the patient, or in other words, the workload that's required. Again, a drastic increase over those 3 phases. Severity patients, I mentioned ESI 1 versus others. So ESI 1 and 2 are the most severe patients. Again, you see the increase there. So which means that the world is becoming more and more increase in volume, more and more complex, more and more difficult for the staff to work in that space. But this is our baseline, this is the scenario, this is the environment that they're operating in. But even with that, when we implemented our tool, the results or the outcomes, 3 metrics that we looked at: door to bed, door to provider, those are both wait times. Length of stay is their time in the ED itself. So door to bed and door to provider, as you can see, the post metric is, the variation is actually, we were able to bend that curve, or bend at least the line that's been increasing trend, we were able to bend it. But length of stay, not as much. And again, that makes sense because, staffing, having the right number of people can only make sure effectively how soon or how we can get them in the door to be seen by the physician and the nurses. But how long they stay is a little bit out of our control because it's also the patient, what they have and how much work needs to be done, whatever needs to happen downstream, challenges in terms of inpatient admissions or discharges to other areas. So those are factors that play into length of stay. But nevertheless, you can see even the median that went up was actually going down for all three, as a matter of fact. Our ED tracks yellow and red status, yellow on the y-axis, the left y-axis, and the red status counts on the right y-axis. Again, based on weights and all that. So again, a significant, I should say significant, drastic change in that as well. This is a note that we got from one of the ED clinicians who was actually really critical when we started this journey. He said, this is, we're not sure this is going to have an impact and it's not going to work. But then he came back to say, of course, it's anecdotal. It's not statistically provable, anecdotal information based on one of his working days. I'll quickly mention about the other initiative where we've used radio frequency identification for real-time location. And the need for that is, this is for those, how many of you have heard of RFID or know about it? So RFID is essentially a chip that helps to provide location information or a timestamp and location combination information. So this is how Walmart knows what is their package in their inventory and what's moved and so on. Why is that important? ED is a very dense environment, staff, providers, equipment, and all that in a really dense environment. Oftentimes the challenge is finding a patient, finding another provider, physician, nurse, resident, or a piece of equipment. This was challenging them in a lot of ways. Plus there are other challenges in the ED because ED, as you saw, is actually very time-based clinical environment. Time to provider and length of stay are all time-based metrics which get reported to Joint Commission and CMS. So we wanted to get a much more robust, standardized way of collecting that, for instance. And 3, for more advanced modeling analytics. A lot of it boiled, we can get a lot of information about the patient from EMR, but one dimension that's missing is their location information. That drives a lot of things where we can improve care delivery. So those are reasons why we decided to implement RFID. Readers that go in the ceiling and staff have their badge with an RFID chip. Patients get a wristband when they register. We went through a whole process of talking to Patient Family Advisory Council in terms of what you thought about it. We had a separate, several town hall meetings with our staff. Legal was involved, human resources, again, to figure out, how would staff feel about it? What was the very first thing they would think of when you say RFID? It was Big Brother watching. So when we went through the town halls, one of the things that we emphasized was this is not to find out where they are at every point in time, but this was a clinical tool to be able to provide situational awareness for the other staff members. And that's all we did. When a staff leaves the clinical space to go to the bathroom or the break room or to have a smoke, the tool is going to drop them off the grid, as you will see. So equipment have stickers, 1.25 acres instrumented with the 734 sensors. I think we have like 500, 600 staff, all have badges. So we have a visual display. So at any given point in time, Dr. Campbell in this case is in OBS 4. It gives you the timestamp as well, so people are able to locate or not interrupt someone if someone is in with a patient or in a patient room. We've had cases where Tonapen, which is a really small piece of equipment, really expensive, $8,000 or something, it's gotten misplaced multiple times. Now we know exactly where to go to retrieve it and bring it back. Resus cases I was mentioning, again, this is something trauma is really trying to get down to providing critical information. So we built an in-house finder tool where you can, just like Google-like feature, you go type in the name of a person. As you type, it sort of narrows down the list. Or if you say fever, it says these are all the patients that are in the ED currently with fever, and which location are they at, how long they've been there. we did a scavenger hunt because an institution came to us and said, oh, great, you got this nice toy, an RFID, and you implemented, and is it even making a difference? So we did a scavenger hunt. So we did not hide things. We sort of staged people or equipment in certain places, like a turn up in an alcove, which often happens, or a patient that might have gone to radiology, and then somebody coming to check them in their patient room. So those are scenarios that we had, and we found a significant reduction in search time. Clinicians in the room, I'm sure, will agree with me on the amount of time that they spend paging each other or searching, looking for things. Patient safety. We use this information to look at contact tracing. So when there is a patient with pertussis or zoster, shingles, when they come into the ED, right now the standard of practice is go to the chart and find out who are all the people that came in contact. But that's going to be only the physician, nurse, resident, and that's it. What about the finance person, the person that cleans the room, or the other patients? So now, with the click of a button, we know as soon as a patient leaves the ED, we know all the people that came in contact with them and spend, either just cross them in the hallway or spend 10 minutes with them in a certain area. So we're able to drill down and provide all that information on the click of a button. Just by comparing that, we found that we were able to improve that contact tracing by 100%. Or in other words, the traditional method of chart review was leaving out half the number of people that potentially could have been infected. So we worked with IPAC for this project. So this is operational now. So staff, clinicians are using it. So again, that's a lot of information. I'm going to just leave you with a couple of things. So I've talked about ED cells. So the next one is in radiology. So we initiated RAD cell. Again, we're going to be hiring 2 postdocs that will be embedded and working specifically in that space. A lot of this actually boils down to one, different disciplines. Not just healthcare disciplines, not just human factors in OR and informatics, but then again, all of us coming together to be able to address the challenge of what is the care delivery challenge that we are facing and how do we come together to address it. And 2, we have done a lot of stuff traditionally studying processes and testing, decision rules as clinicians or groups of care providers might think, okay, let's try this out. But then, we've done stuff discovering from data, but then how do we bring that together to inform some of those challenges to be able to make meaningful impact at the end of the day? We embed learners as part of our journey as well. So all of those activities, we have postdocs, we bring in summer interns. So we want to get them to also partner up with people from other disciplines through the process so they see the value of teamwork and collaboration in such areas of care. So that's a book on informatics, which are in the process of updating. We're going to have a second edition soon. And none of this would have been possible without the Kern Center. Great colleagues from surgery, emergency medicine, and now radiology. And of course, my team. Of course, somebody once told me, if you want to get good stuff done, make sure that you have people that are really smart, and then make sure that you eliminate barriers in their path. Happy to take questions. Yeah.
So you mentioned about and first of all, thanks for the presentation. That's great. Question about the overutilization and underutilization of OR time. Did you do a study to see which one is worse based on whatever metrics, for example, cost or whatever it might be, or how much of underutilized OR time is equivalent to how much overutilization time?
So we didn't specifically do a study to actually quantify that. So the way when we model it, we actually weighted them. So in our case, we just wanted to. So in our case, overutilization, of course, you're going to pay for more staff. So that was more expensive from that perspective.
Right.
So again, erring on one side versus the other. So again, the way, our model figured it, took into account is, okay, whether you have more cases added to a day, so you're going to have additional staff working. So you leave it to, if it's a really emergent case that can be scheduled and it had to be done. Of course, it's okay to go overtime and do it. So it's not going to restrict the team from doing it.
Right.
But it provides that information to say, both are bad. But again, if the procedure has to be done, then of course you need to schedule it.
So elective surgeries that could wait, a couple days.
Right.
Or something.
Yep.
So just kind of like a rule for the scheduler to know if they don't schedule it, then you potentially could lose revenue.
Right.
And if you do schedule it, then you potentially have to pay for additional people to wait.
Right.
So kind of the decision rule of to schedule or not to schedule.
Yes.
Right.
Yes.
I was curious, so for the tools that you create, are they integrated? You said you guys are moving to Epic.
Yes.
So are they integrated with the electronic medical record and the existing systems, or are they separate? And does that affect how many people use them and stuff like that?
So that's a great question. So, but there are two parts to the question. So, I mean, are they integrated? Some of the, a lot of the tools actually pull real-time data from existing systems, like the surgical tools. They're all work in real time, pull real-time information from existing tools, but those don't have any write capabilities at this point. Moving forward, when Epic comes by, so, these tools, the ones where we need to integrate with Epic, so those are ongoing discussions right now. The ones, but there are tools like the capacity management one or the staffing one. Those do not have to read or write anything in real time, because those are more, you do it after the fact to inform certain changes, but then you implement it, and so those can be offline. The one about RFID, Epic does not have RFID, so we came up with a new version of the user interface. I showed you one, but we actually went to a newer version of the same thing, a newer model. And RFID is still integrated into that because Epic does not provide functionality for RTLS RFID.
Okay.
Yes?
One of our online viewers would like to know what company makes the RFID technology that you're using.
So the question is, what company makes the RFID technology? So when we started this journey, our RFID vendor was Odin, O-D-I-N. They have since been bought by Quake Global, Quake as in earthquake, Global, Quake Global. So we work with them, but they primarily provide the readers, the hardware, and the filtering algorithms or the software which does things like, triangulation. Multiple readers picking up a tag, so using the energy level to triangulate and say, where might you be with a certain level of certainty. So they do all those filtering algorithms, and then up until that point, all that information is still de-identified. It comes through our firewall. It is at which point we actually assign it to say, this is Dr. X or Nurse Y, or this is Patient Smith, and so on. So we've done some in-house build for this. There are other vendors, providers out there, and there are also other technologies out there. That if you're interested in RTLS, you might want to look at Bluetooth, infrared, or even taking advantage of existing Wi-Fi technology that you can take it to the next level. Other questions?
Are you doing RTLS at a curtain bay level?
RTLS at a curtain bay level. So another good question. So how much RFID RTLS do I need? That's a fundamental question. So my suggestion would be the clinical need should drive the technology. So of course you bring in a vendor and they're going to say, yeah, you need to have 800 readers. Maybe you don't. Maybe you do. But really depends on the clinical need. Are you trying to just capture are you trying to just know where are your people at and where is certain piece of equipment that gets lost? Or wheelchairs, are they getting lost, and that's what you want to focus on? Are you interested in automatic reporting for CMS JCO purposes? Are you interested in more of patient safety kinds of things, hand washing? People have explored RTLS RFID for hand washing purposes. Or are you looking at things like some of the other work that we have done? So And I think trying to come up with at least an understanding of what areas that you want to focus on is going to drive how dense of a RTLS system do you need. Do you need 3-4 readers in this hall right here, or maybe you just need one, or maybe you need just there are 2 doors. So one of the examples where we talked about is, for one of the applications at Mayo, they wanted to just know whether a piece of equipment entered is in a certain wing or not. So in those cases, you just need to instrument the doorways or the entry points to that area, and you don't need in all the entire area within that space. So all of those questions will dictate how many readers and how much density you need to have. Other questions? Yeah.
So does the system allow you the RFID? Does it allow you to do continuous evaluation of time, or do you project or do you do that?
Yes, actually, some of the projects that I listed earlier, so we are starting to do exactly those. So I had listed a whole bunch of projects here, but things like we're starting to look at patient alone time. So how much time is a patient alone in the patient room? Because there is evidence in the literature that patient's length of stay in the ED is a strong predictor of patient's length of stay in the hospital. Now, we feel that patient alone time, well, it's sort of related to their length of stay, but we also want to know from a time standpoint, but we also want to know if a patient being alone for a long period of time, is there a chance for things being missed out so that somebody might have to check in on them? So we're trying to explore if we can use alone time for RFID for patient alone time, evaluating that on a real-time basis, and say if somebody's, let's say there's an art team going on, and then there is somebody's getting paged, and then maybe a patient is just, nobody's checking in on them for 40 minutes. Maybe that's, maybe they went to the restroom, maybe they had a fall. So trying to create alerts using that. So that's more on the clinical side. On the research side, again, we're using it for left without being seen. So a lot of left without being seen in the ED is a major issue. And nobody has, I shouldn't say nobody that without RTLS or RFID can have accurate data on when they exactly left or why they left. We know exactly because the moment they walk out the door and they never came back, that's the time we know that they physically left the department. It's not the time that's much later when the nurse called them in the waiting room and then they didn't show up. That still might be, half an hour, 45 minutes, or more than an hour later when they're being called. But the patient probably left much sooner than that. So we are able to accurately identify that left without being seen time or the abandoning time. So we're using that to see what are factors and how can we work on some of those. Other questions? Thank you.